Well, I found out in the early part of 1986 in New Orleans. I had a venereal disease with discharge, so you got to go get a shot in the butt and a couple pills. And they had a sign free testing for HIV. So I've got the venereal disease medication, and a month later, they sent me a notice for the HIV stats. And when I went to, they called me to come in there. And as I went in for the appointment, the black lady behind the desk was in eyes welling up, and she was in tears. And immediately I knew what the answer was. And we both started crying together. When I did finally get with the medication and the literature, sometimes you want to make sure there's nothing pertaining to or of AIDS, whether it be magazines, whether it be a pamphlet, whether it be some medication. The thought was, if I get everything away about HIV, I won't have it. Of course, we know that's not right. Stick your head in the sand. So about 10 years from the day I got it, and I started breaking down in 96, and it was not easy. My T cell count went down to 10, which is not very high. And I had several doctors to tell me to get my affairs in order because I wasn't going to be around much longer. I'm like, how do you wrap your head around that? It wasn't one time, it was 3 different times. But here I still sit. And for 10 months, I felt like a cancer patient with chemotherapy. And I asked Dr. Wong, I said, I can't do this. He says, well, Renard, if you come off the medicine, you will feel better initially, but you're just getting it to reproduce more. It can even change. She said, you'll see me down the road or the coroner. So you take your choice. I said, okay. That was in 93. 97 is when my body broke down on me, and I had to get back on the medication.
In the 80s, when I had someone that was HIV positive, their life expectancy was 2 years. If I find someone now with acute HIV infection that's 10 to 50 days after their exposure, and I start them on medications, their life expectancy is 69 plus years. That's how far we've come. In the beginning, there were patients taking 40, 50, 60 pills a day. Now I can treat HIV as a chronic illness like diabetes and hypertension with 1 pill a day. It's a game changer.
In the US and in Canada, we have this thing called the care cascade. I think in Canada, some people call it the engagement cascade. And it is, okay, this is how we're going to get ahead of HIV and perhaps even end it as we know it. It doesn't mean that HIV will disappear, but it will end as we know it. So we must get people diagnosed so that we know who's living with HIV and who isn't. That tells us about the general magnitude of the thing. Then, we must once people are diagnosed, we must get them into care or treatment, get them the care or treatment that they need. And we monitor them along the way. And if we follow all these steps, then we get to zero.
Treatment as prevention. So there is an acronym, U equals U. It means undetectable equals untransmissible. Almost 15 years of data supporting this, that U equals U, undetectable equals untransmissible.
Treatment is prevention. That if I'm taking my medication, I'm HIV positive, I'm less likely to transmit it to someone else that I'm with. Understanding that you can be in relationships with someone who's HIV positive and not get HIV. And you can have kids and a life.
PrEP is a protocol to prevent people from getting HIV. It's pre-exposure prophylaxis for HIV. It has 4 parts to it: a daily pill that you take. It has screenings for sexually transmitted diseases. It has a part in which people are taught safer sex instructions, and also risk interventions, how to decrease their risk.
So the way it was always described to me, and I like to describe it to people this way, is a birth control for HIV, like a birth control pill for HIV. So you take it when you need it. So as women take birth control pills when they don't want to have kids. So we take PrEP. I don't want to get HIV, and I know that either what I'm doing may pose some risk, or what my partner is doing may pose some risk. Because we have people who know that on their side of the relationship, that's their only partner, but they know that their partner may have other partners or may be involved in other risky behavior like injection drug use, different things like that. So when you're looking at PrEP, it's not just what I'm doing, it's also what the person that I'm having sex with is doing. And so it's important because I think a lot of times people just see it as a medication for people who are MSM, so men who are having sex with men.
HIV stigma is also linked to homophobia. A lot of people believe that HIV is something that only people who are gay get, right? So if you're not gay, if I'm not gay, then I can't get HIV, therefore I don't need PrEP, right? And then we also look at HIV as, well, if you got HIV, you've been out here, doing whatever, having sex with whomever, so therefore you've been promiscuous. And I think that also too plays into people's perception of, well, I don't need to take PrEP because I'm not gay, I'm not out here sleeping around, therefore I don't need it. And they don't think about, or they're not taught to think about all the other ways in which you can get HIV. If you are sharing needles, you can get HIV. HIV is not just for gay people who are promiscuous. There are people who have been in heterosexual marriages who've gotten HIV or whatever. So I think people don't want to take PrEP because they don't understand what HIV is.
I think a lot of people think it's for gay men. I think that they think that it is transgendered individuals, and those are the people that are getting HIV. So if I'm not that person, or if my partner is not bisexual, I don't have anything to worry about. We know that people who are injecting drugs and using other drug paraphernalia that they're sharing, the numbers for HIV have increased. We know, like I said, that Black women have a higher rate of HIV positivity rates than other women, our white counterparts. We know that our youth are being exposed to HIV at higher rates because right now in this generation, it's a good thing that people are more honest about their sexuality and having more conversations, but they're also taking more risk.
So although PrEP is an HIV medication, it's strongly associated with HIV treatment and antiretroviral therapy. So there are, people have concerns about taking PrEP, for instance, because they don't want to be associated with someone living with HIV and someone accessing antiretroviral therapy. So in some of my earlier work, I wanted to really understand more about the potential for stigma and concerns and barriers to African-American women and young girls taking pre-exposure prophylaxis or PrEP. So this is in qualitative work. So, this really suggested that we have to do a better job of educating communities, especially those communities that are highly or disproportionately impacted by health disparities such as HIV. So women and girls, Black women and girls really, said, hey, if we're the most affected, we should be the group to learn about PrEP earliest. Although we know that white gay men were, in terms of when we think about early adapters of technology, they were at the forefront of accessing PrEP treatment and knowing about PrEP. And many African American women felt like they were being left behind in terms of PrEP education. Many providers were not having conversations with Black women about taking PrEP, whether or not that's someone's OBGYN or their primary care physician or an internal medicine physician. So there are clear gaps in terms of Black women being engaged adequately and delivering information about PrEP to other Black women. So that's definitely an area that needs intervention.
We also have to be honest, like we're talking about African Americans. African Americans rarely trust a lot of like medical innovations, and rightfully so, right? Like they have legitimate reasons why they shouldn't. History has shown us that, you know, the discovery from medical innovation has oftentimes been built off the backs of Black folks, and not in a good way. And oftentimes we haven't benefited from that. And so why would I trust a system that's a part of a larger system that I feel has never really benefited me from in the beginning?
Black people are distrustful of the medical system and of Big Pharma because, you know, again, going back to the historical legacy of dehumanization. For example, in the text "Medical Apartheid," some of the historical practices of the white man deemed the father of gynecology, James Marion Sims. You know, that text discussed the ways in which he experimented on Black bodies that were enslaved, in particular, you know, Black women. So, for example, you know, medical condition, you know, vaginal fistula, right? Bleeding out, especially associated with childbirth and child rearing. He experimented, he engaged in the practice of science with Black women's bodies, for example, without anesthetizing them, right? And so he did that. One, because right, he was operating as a doctor on slave plantations, and so the regard for Black body was not there. But additionally, there was this misperception that Black bodies have a higher tolerance for pain, right, than anyone else. So you know, we tough. You know what I'm saying? We take a lot. You dig? I own that. We are tough. We tough. But to say that we are going to facilitate invasive medical procedures onto your body and project onto you the belief that you can tolerate this pain, you can bear the pain, but then, you know, once you've engaged in that science, right, and have identified certain quote unquote discoveries of how to address medical conditions, you translate those scientific and those medical practices to white bodies, and you ensure that the care associated with reducing their pain and ensuring that, you know, their subjection to comfortable medical practices, you ensure that that's the context of their care, right? And so associated with that historical treatment is cultural memory, right? So those narratives, that physical pain, that trauma associated with those practices, those have been passed down from generation to generation, man.
We think about ethical violations and reasons to employ human subjects, guidance for researchers conducting work. The Tuskegee syphilis study is an excellent example of that because, one, men were misinformed and actually deceived into thinking that they were being treated for syphilis or bad blood. The study was attractive to many of the men because African Americans and their families did not have access to adequate health care during that time. They also didn't have access to decent housing. Secondly, when penicillin became available as the drug of choice to treat syphilis, men were not treated with syphilis. So also other accounts that men were actually discouraged from taking penicillin, and people around and who were part of the community were also discouraged from offering men who were enrolled in the study penicillin to treat their syphilis.
The way our medical system is structured, in that when you go to your primary, you may often be visited 15, 20 minutes. And in that time frame, the provider is documenting as well as taking a history, making a diagnosis. Questions don't always get asked in the time that's allowed. And patients may be coming to the offices. We don't have health education classes like we used to when I was growing up. And so people really don't have a good knowledge base a lot of times of what their health issues are, what it takes to keep them safe. And insurances change. So the rapport that you used to develop with your primary care physician from the time you were little to the time you died, that doesn't often happen because they're not on the insurance roster for you to choose. And your records may be so exhaustive that they aren't reviewed as well as they could be, or the person taking care of you may not have knowledge of prior conditions that you assume are being attended to. So it puts a lot of responsibility on the patients and a lot of responsibility on the providers, but patients do the best job they can to get information. We as providers should be the source of accurate information for our patients.
In my work as a social and behavioral researcher who also engages in ethics, I have experienced multiple examples of HIV/AIDS-related stigma by engaging African-American women living with HIV. So one example includes some of my formative work where I was engaging women, going to their homes to conduct interviews. And when I arrived at their homes, many women said, "Thank you for coming to my home. However, I can't let you in to actually do this interview." I later learned from women when we decided to conduct interviews in different places, including my car, that they hadn't disclosed their HIV status to the people that they lived with. So this was one example of the way that stigma might intersect and manifest to impact someone's concerns around disclosing their status to someone else, because it can have harmful ramifications, both socially, physically, and can lead to other forms of discrimination and harms to an individual. When we think about healthcare, there's an emerging literature that really suggests that healthcare might have even more negative effects, more adverse effects on individuals because of accessing treatment, accessing care, and accessing prevention. So in my work with Black women living with HIV, I've learned from women that during pregnancy, around pregnancy decisions and other reproductive decisions, physicians sometimes have the tendency to discourage women from having babies, discourage them from engaging in childbearing, discourage them from, actually there's evidence that suggests that sterilization is encouraged for women living with HIV compared to women who don't have HIV. So again, although we have successful interventions that prevent mother-to-child transmission for individuals, the actual risk of mother-to-child transmission in the US is less than 1%. We still find that physicians discourage women living with HIV from reproducing.
I think that stigma in the Black community keeps people from being tested or being treated even. I've heard stories where people had their meds hidden where family members could not find it out that they were positive. So I think that the stigma surrounding it keeps people from being educated or treated, and therefore the numbers keep increasing in the Black community.
So stigma affects HIV prevention in a lot of ways. So we have a vehicle outside and it says like proud to know, and it's about HIV testing, and a lot of people know and associate that van with as the HIV testing van. In Louisville, we had a series of people testing positive. So a lot of people's like, I don't want to go in that van because if I go in there, someone's going to think that I'm positive. So even though this positive message of I'm proud to know my status and it's important to know your status became something that people kind of shied away from because they equated it with being positive instead of equating it with, if I know my status, I can get the help that I need and live a healthy life.
People still have that stigma and they're afraid of being labeled. So if I tell somebody that they have cancer or they have diabetes, they'll go home and they'll talk over the fence or down the hall to their neighbor and they'll say, honey, do you know what the doctor told me today? And the family member or neighbor will say, whatever you need. If you need me to watch the kids or to go get a loaf of bread, you just let me know. I'm there for you. But people are afraid to share this diagnosis. And we are a social culture. We need the supports of our family and our friends and our community to treat this, to preserve life.
When I got sick and had AIDS, my mom lived in California, and she got news that I had HIV/AIDS. I was dying. So she got my sister, oldest sister, to come and take me to the doctor. Of course, I'd been going to the doctor, and I didn't need her help because I had my own little system set up. But my mom says, well, let her take you anyways. I said, no, I have people to do that. I've been doing it. Then Mom says, well, do it for me. Let her come and take you for me. And I'm like, this is very strange. Are they trying to atone? Are they trying to make right? You know, they're Jehovah's Witness. And my mom asked my sister, should I come? And my sister said, I can't tell you what to do. But anybody with any horse sense would say, you need to get home and see your son. But my sister never told her that. And when my mom finally was coming to Kentucky back home, visiting to see me, the conversation was, what did you tell your friends, your lady friends? She said, they asked me, Mary Ann, why are you going back home? She said, my son has cancer. She could not say AIDS. I had a niece who was just terrible. And she was young and immature and a child. But she uttered some words to me that I will never forget. She says, I hope you get AIDS and die. She didn't know I had HIV. Nobody in the room knew I had HIV, but I knew. So how do you deal with that? But to this day, she's never apologized to me for saying those words. Although when I see her, she's got her arms wide open. I'm her favorite uncle. She wants to give me a kiss or whatever, but she still has not apologized for saying those words to me, which I'll never forget. I have a family that's like a quilt. You don't have to be the same blood, but they have compassion, a heart, empathy. And it takes that. And you can't expect your family to always be and do what you want. So the ones that don't want to be around me or anything, that's fine. But I have a whole different family. Like I said, it's a surrogate. And we pick and choose and do the right thing. And I find that people who don't even look like me. When I was real bad shape, I live in the country, live in LaGrange. There's a church that a friend of mine had gone to. He had the whole church to pray for me. They sent me a card. Every parishioner, everyone signed this card. And they said, we are all going to pray for you. There is, and I honestly believe the prayer helped as much as the medication did. Yeah, loudspeaker, hey, God, and I know it helped, without a doubt. Well, you have to be really diligent. You have to nip it in the bud. It's already started. If you've got it, you need to take care of going to all your doctors. And if you're scared and don't know, call me. I don't mind. But you've got to do your homework. I have helped 3 individuals, and all 3 of them laid down on me. They didn't do their homework. They ended up passing. When I told them, hey, look, I'm a classic example that it can be done if you stick to it. You've got to go through the regimen. You got to take your pills. You got to eat right. You need your sleep. No stress, no diesel drugs. You've got to do right by your body. You only got one temple, and you need to take care of it.
And so we have to educate ourselves, even if it's not for us. We have to educate ourselves for our children, for our grandchildren, nieces and nephews, so that we can end it. And we have to quit shaming people for what they're doing. Because anything that you do in the dark, it's often done wrong because you're sneaking to let people know that this is still real. And we cannot continue to sweep it under the rug and not have these conversations. Very manageable, but still real. So I don't want to be diabetic, even though I can manage my diabetes. I don't want to be HIV positive, even though I can manage my HIV. If I get it, I know what I can do to be safe and healthy, but I can prevent it. And so we have to continue to have those conversations, and we have to continue to meet people where they are. So going into those communities where people are less likely to go to doctor's offices, less likely to seek help, so that we can be that bridge to the medical profession. And so just one last thing with that, we know that a lot of populations have bad experiences with the medical population. So injection drug users, that's hard. Our hospitals are already overran, and then you have someone in here who's doing something to themselves, makes you kind of feel some type of way, or you're afraid to go. Black people have had bad relationships with the medical population as well in the past. And so we have to be that bridge to let them know that this isn't a bad place. They have a lot of resources, and you need to go to take care of yourself to be happy and healthy.
Thinking about the restoration of trust or the repairing of trust, we have these instances historically where maybe men early in the Tuskegee syphilis study did trust the government. Maybe they did trust the healthcare system. But again, over time, these negative interactions and untrustworthy actions from government agencies, public health agencies, our national leading organizations, agencies have really diminished and decreased the trust that communities and patients have towards healthcare generally. So what we're seeing now during the COVID-19 pandemic, as of April 2021, the Centers for Disease Control, or the CDC, acknowledged and declared that structural racism is a threat to the public's health, disproportionately and negatively impacting the daily experiences of individuals, the healthcare experiences of individuals. So when we think about repairing or restoring trust in any sort of relationship, we have to first acknowledge. So the good thing now is that people are acknowledging, agencies are acknowledging that structural racism exists and that there is a history of harms being imposed on African American communities related to health and healthcare. So that's the first step. The second step is really taking all of these acknowledgments and declarations and manifestos even, and making sure that those things translate into programming and investment in Black health and in the Black community.
So there are a lot of factors for medical mistrust, and not least of all is the fact that we've done studies that show patients and doctor interviews lasts longer or more in depth when the provider has a similarity to the background of the patient. We know this. And so we need to have more providers that look like our patients, more providers that are culturally sensitive to the needs of their patients and to the barriers that prevent them from obtaining the health that they should have. We need health equity in our country.
When I was younger, footloose and fancy-free I was. Now at 61, I like sitting on my porch. I've dealt with this HIV since 86, and I've dealt with the AIDS since 97. So I've been at it for a while. Nobody said it's gonna be easy, but it's doable.